So good morning, everyone. I just wanted to discuss a case that I did with Satish some months ago. It's actually Steve Nemagon's case, but we sort of got involved for a hot second, but it was interesting. So this is a 74-year-old lady. She has systemic mastocytosis. She's taking midostaurin for that. Also had an aortic pseudoaneurysm for which she had an EVA. Now she has had multiple admissions with anemia and melena. So this is her admission in June of last year, June 1 of last year. This is what was found initially. So as you can see, she has GAVE in the antrum, and it was treated with APC at that time. Continued to bleed, had another EGD a couple days later. This is what it looked like post-treatment, but there were still a couple areas that were still oozing. So that was treated again. She continued to bleed again a couple of weeks later. The areas that were previously treated seemed a bit better, but there were still a lot more areas of either new GAVE or residual GAVE. So that was also treated again. And again in September, so that bought her a couple of months. She presented again in September, again with GAVE, treated. And then in October, similar presentation again. So she, after all of those times of having recurrent bouts of APC and coming back again and again with oozing from her GAVE, we decided to try another technique. So here, what you're seeing on the screen is the RFA probe, and this is what we're using to treat the GAVE in the rest of, well, in the entire antrum region. So we're going like circumferentially applying currents to each of those different areas and really trying to effectively burn off all of the GAVE. Yeah. Okay. So at the end, okay, so at the end of the treatment, this is what the antrum looked like. You can see that they're like circumferential burns across the entire surface, and we were able to get pretty good treatment of most of the surface area. Now, she again had anemia 1 month later. So of course, given her history, the initial thought that this was GAVE again. But when the endoscopy was done, this is a marked improvement from her prior endoscopies, and there's basically no residual GAVE. All of these little shallow ulcers you see are likely as a result of the treatment with the RFA. So she ended up undergoing a capsule endoscopy, and they found these raised nodular hyperemic lesions. And Steve actually biopsied those, and those actually came back as mastocytosis as well. So Hemonc, I mean, I haven't seen any change in the therapy, but they're managing her supportively in terms of the blood transfusions, as it's nothing that we can intervene upon endoscopically, and continuing her midostaurin. So this case has a bunch of very interesting different features, but I just wanted to focus on one of them, which is where we were involved, which is really the role of RFA for management of GAVE. So traditionally, APC has been used as the primary modality for managing GAVE, but this can require multiple treatment sessions in order to be effective. So RFA has been shown as a reasonable alternative, and it involves applying high frequency alternating current to the mucosa. And the advantage of this is that each of those probes can deliver a larger area of treatment for every application of it. And then because the current is preset, you have a more controlled depth of the thermal coagulation necrosis. So there isn't a randomized controlled trial directly comparing APC and RFA. But there was a meta-analysis that looked at all of the studies done on APC for GAVE and all of the studies done for RFA on GAVE. And what they did is that they did a PubMed search a literature search for all of these. And after excluding all of those that were duplicates, just observational studies, basic science articles, they ended up with 33 studies, of which 24 studies were done on APC with an N of 508, and 9 studies were done on RFA with an N of 104 patients. So the primary outcome was to determine what the efficacy of APC and RFA were, as measured by clinical and endoscopic success. Clinical success was defined as the improvement in pre and post-procedure hemoglobin levels, as well as the patient's dependence on red cell transfusion after treatment. Endoscopic success was a bit variable, and it was defined as the need for follow-up endoscopy post-procedure, as well as whatever the authors deemed as being endoscopically successful. In terms of the secondary outcomes, they wanted to assess the tolerability and the feasibility of the procedure, as measured by the complications that occurred, as well as the number of endoscopic sessions that were required to achieve clinical endoscopic success. So when they distilled it down, what we can see is that for APC, more sessions were needed than RFA to achieve clinical and endoscopic success, and more complications occurred in the APC group compared to the RFA group. However, in terms of what is defined as endoscopic success, which, as you remember, was sort of variable between the different studies, RFA was noted as having a higher endoscopic success compared to APC. However, APC resulted in a higher increase in post-procedure hemoglobin levels, and also decreased transfusion requirements post-transfusion. So all of this sort of suggests that APC may require more treatment sessions, but might actually have better outcomes. But if we look at the subset of patients that RFA was done on, it's really 47% of these patients already had APC done. So this was a more refractory group of patients. So I wanted to take a closer look at that cohort of patients to better define the role of RFA in the management of GAVE. So this is another article. It's a prospective study that was done looking at RFA for patients with refractory symptomatic anemia secondary to GAVE. And it's prospective, it's single center, and it included anybody who had an existing diagnosis of GAVE, persistent anemia requiring blood transfusions, previous treatment with either APC, laser, or banding, and visible GAVE at the time of endoscopy when they went in to do the RFA. They excluded anybody with active malignancy, alternative causes for anemia, and any anatomical abnormalities that prevented RFA from being used. So their protocol was that they used RFA to all areas of GAVE that they could see. Then at 6 weeks, everybody had retreatment to any areas of residual GAVE. So everybody was rescoped after 6 weeks. If they had residual GAVE, they got treated again. And then after 8 weeks, a repeat endoscopy was done to assess the effectiveness of the treatment sessions. After 10 weeks, they followed up their hemoglobin and checked to see how many transfusions they required after they've undergone treatment with RFA. So their primary outcome was to see a sustained increase in hemoglobin 6 months after 2 sequential RFA treatments. And the secondary outcomes here were to assess the reduction in blood transfusion requirements or IV infusions of iron over the 6 months after they got treated. And then also they wanted to take a look at the endoscopic surface area regression of the areas that were treated with RFA. So this is a European study. So their hemoglobins are listed in grams per liter. So the mean hemoglobin before treatment was, in our conversion, would be 9.5 milligrams per deciliter. And then post-treatment, it went up to 11.2. And in terms of transfusions, 70% of patients required transfusions pre-treatment compared to 21% of them. In terms of the surface area regression of the areas that were treated with RFA, pre-treatment patients had the area that was improved post-treatment with RFA was found to be 74% compared to pre-procedure. And there were very few adverse events. Only 1.5% of patients reported pain, and it was pain that was not severe. They can manage it with oral pain meds. So based on the meta-analysis that we have and this prospective study, my take-home points from this are that both RFA and APC are effective modalities for management of GAVE. They may require multiple sessions, but they are effective. And there is some suggestion that APC may be more effective as an initial treatment. However, in terms of refractory GAVE, RFA is very effective, and it may have a better safety profile compared with APC. In order to better define which of these is more effective, I think there is a need for some sort of head-to-head randomized controlled trial. And then it would be interesting to have crossover arms as well to see which sequence of therapy would be more efficacious in achieving remission of GAVE with less treatment sessions. So that is me. Thank you.
So,
questions.
All right, so very interesting, and thank you for presenting that. It is definitely becoming a more popular modality for treating not only GAVE, but its related, if you want to call it, its sister condition, radiation proctopathy. Same thing, mostly for refractory radiation proctopathy. Maybe you can comment. With APC, it is not a set energy level. If you look in our IRBI system, there is a different energy level for APC esophagus, APC stomach, APC duodenum, APC rectum, APC colon. And those are not based on anything other than, our local rep or the manufacturer's suggestion. For example, we would use a lower energy in the duodenum or the cecum compared to the thicker walled stomach. With RFA, it is a set energy. For APC, we're looking at things like 20 watts, 30 watts, maybe 40 watts. With RFA, the energy is delivered in joules, and usually we're using this for Barrett's esophagus and Barrett's neoplasia. And for Barrett's neoplasia, we're usually using 12 joules per treatment. And the other part about when we're using RFA in Barrett's is that patients get 2 for each area. You apply the probe twice, you clean the area of the coagulum, and then you repeat the treatment twice in each area. So I don't know if you've come across anything regarding, what is the energy comparison between these two modalities? What is the depth of injury between APC and RFA? And was there any information you can come across whether or not RFA for GAVE is the same protocol as we use for Barrett's? I've done this for GAVE, and I usually just do 2 applications. I don't do the cleaning of the coagulum and repeat, but I would love to hear your thoughts and maybe shed some light on that.
To be honest, in the studies that I look at, they just mentioned that they used 12 joules of energy, but they didn't go into detail about how many applications were used each time. And also, I didn't see that there was the only comparative study that I found between APC and RFA was a retrospective study, and there were variable settings for both of them. So it was very hard to make any sort of comparison between the energy settings.
Because there's a new modality of APC called hybrid APC. So the concern when using APC is that you'll get deep injury into the submucosa, and when the eschar falls off, you may expose these big submucosal vessels and have delayed bleeding. Hybrid APC is a technique where you inject a submucosal fluid cushion. That way you separate the mucosa from the submucosa and the muscle layer, but then you use super high energy levels in order to really ablate the mucosa or the mucosal lesion in this case more effectively than you would with standard APC. So I do wonder if it's just a heterogeneous population of patients with different settings for APC, different protocols for how they're doing the RFA, if it's really fair to make that comparison.
Hey, Chris, my theory, I mean, the APC, as you mentioned, it's really just sort of unregulated. The depth of penetration is probably related to how long you have your foot on the pedal, whereas RFA is actually a pretty precise depth control, and I have to wonder if some of the effective APC really is dependent on how deep you have cauterized. You know, will you get more scarring or less or more vascular remodeling? And so, you know, comparing APC, which is so erratic, versus RFA, which is more precise, it's not a fair comparison.
Yeah.
Hybrid APC may level the playing field because you're injecting all that submucosa and just burning the top more accurately.
Out of curiosity, has anyone done this or looked at this for cryoablation?
I didn't look for it specifically, so I'm not sure.
I believe there's some limited stuff, but certainly not to the level of the RFA data. It's probably more, just like it is for Barrett's, it's probably more case series as opposed to anything beyond that.
Yeah, I haven't seen anything for cryoablation, but
what do you guys think about? I'm going to call it like training for RFA. I think the lore out there is that RFA is somehow more dangerous. Like everybody's doing APC and not everybody's doing RFA. And is it time to dispel that? Because I don't know that they're so different.
I would agree with you, Dave. RFA is pretty easy. Really the issue is just setting up your scope, but it's mindlessly easy to do. There's nothing really special about it.
Right.
You do like a case, like get proctored once, and you'd probably be fine. I think Barrett's thing is more complicated just for recognition of EMR or whatever. But I totally agree. RFA is really simple once you've seen it done.
Thanks.
and most of the nurses and techs know how to set it up. And like Satish said, it's pretty foolproof. I mean, it's a set energy. You step on a pedal, you apply the probe, you step on a pedal, and it's pretty safe. So very cool.
Great case.
All right. Thanks so much, Akira.
Thank you.
I can do the mastocytosis stuff another time.
Yeah, that's the other very interesting thing about this case.
All right, so I guess Christina had flooding issues, so we're gonna go to Nick.
All right. All right, today I'm going to present a retrograde, endoscopic retrograde cholangiopancreatography, which I will explain momentarily. So the patient was a 61-year-old female, multiple abdominal surgeries. Most importantly, or most relevant, she had a history of gastric cancer, and she had a partial gastrectomy with a Bell-Roth 2 anastomosis. She also had, during that treatment time, neutropenic colitis and a colonic perforation with a colostomy, but that was reversed. And then she had an elective cholecystectomy at an outside hospital. Post-operatively, she had ongoing abdominal pain. She became tachycardic. They scanned her and they found new ascites and sort of enhancement of the peritoneum consistent with peritonitis on imaging. And there was a concern based on those findings for bile leak. So they took her back to the OR and they placed a drain, which had bilious output. And then she was transferred to us. So this is the post-op imaging. As you can see, there's just fluid consistent with ascites that was not there pre-procedurally. So before I get into the endoscopy, so she had a bile leak. She needed an ERCP for treatment of the bile leak. And the complicating factor in this case is the post-surgical anatomy. So on the left is a normal ERCP, I guess it's an ERP for some reason, but it demonstrates basically the position of the scope, which is that you go through the stomach, through the pylorus, to the duodenum to approach the papilla. In the normal position. On the right is a post Bell-Roth 2 anatomy. And basically there are a couple complicating factors. The first being you have to go down the pancreaticobiliary limb, which is a variable length depending on the surgical details, and you don't really know how long that's going to be or whether you're going to be able to reach it with a duodenoscope or an upper scope or a colonoscope. And then also this image sort of highlights that you're approaching the papilla from the opposite angle. That's where I get the retrograde, but you're basically going retrograde up the duodenum and approaching the papilla from the other side. So all of our tools that are oriented for a classic ERCP are now basically oriented the wrong way and everything is upside down. So this is, from this case, the major papilla viewed from that retrograde position. And this is here basically as the case progressed. So cannulation was very difficult. We were able to place a wire, although it went into the pancreatic duct. And you can see that on the right under fluoroscopy, that there's a lot to unpack on this fluoro image, but I'll go through a couple things. So this part is a surgical drain. This is from the X-lap. These are just staples. These two circles are markers. And these clips are the cholecystectomy clips. So you can expect the biliary tree to be over on that side with the cystic duct going to those clips. So what's illuminated here is you see the scope coming down and you see a catheter up in with the wire in the pancreatic duct and contrast in the pancreatic duct. So that's where we were first. And so at that point, since it was the only access that we had gained and we had not gained access to the biliary tree, we elected to place a pancreatic duct stent. And that allows us to do two things. One is it protects against post-ERCP pancreatitis by keeping the pancreatic orifice open and reducing that intrapancreatic duct pressure that we think causes the pancreatitis. And also, this provides a sort of backstop for doing a pre-cut sphincterotomy, which was the next thing that we proceeded to do. So this is a video of a pre-cut sphincterotomy. What you're seeing is the pancreatic duct stent is green. The needle knife is that tool that you see on the right. And the sequence of events is essentially you make shallow, again, safe cuts. You have that pancreatic duct to prevent you from perforating as long as you're going along the duct and along the stent, and it also orients you as to which way the ducts go. And so you make a series of cuts progressively deeper, progressively extending the sphincterotomy, and in between you can attempt to see if there's any way into the bile duct here. So this is, using a tome, trying a wire, and then, further cutting. So here we see a rush of bile, which is a great sign. So now we have definitely opened up the bile duct. We just have to sneak a wire in, and this wire does go into the bile duct. So here you just see the tome extending into the bile duct. And you can actually see the biliary orifice down at the bottom here. Okay, so after achieving biliary cannulation, we injected contrast. On the left, again, I'll go over what we're seeing on the fluoro. The arrow is pointing to this surgical drain. The contrast is now in the bile duct. This is the common duct, which is dilated. And then you can see the intrahepatic ducts at the top. This is a non-pressure injection, which is that we just use a catheter to inject contrast sort of diffusely into the duct. In the middle image, you can see there is now something in the duct. This is a balloon inflated. And so this is a pressure injection. Now there's a balloon occluding the duct, and we're injecting beyond the balloon under pressure, which forces the contrast through to try to illuminate the leak. And now you can see near the arrow, there are these slender ducts leading past the cholecystectomy clips down to this area of contrast extravasation. And you can also see the surgical drain is much darker in the middle than it is on the left because the contrast is flowing out into the surgical drain, indicating that there's flow from the biliary tree into the peritoneum. And that is the leak. On the right, you can see a magnified image of the leak.
Where is the leak from? Shouldn't your balloon be lower?
So this is the interesting point about this case, is that this is not a leak from the cystic duct. This is actually a leak from these slender ducts, which are ducts of Luschka. So you can see them coming off. It looks like they come off here from the right, and then they kind of wrap around and come down and leak into the gallbladder fossa there. That was our interpretation of that. So we placed a biliary stent, and then the final fluoro shot is on the right with a biliary stent and a pancreatic duct stent in place. So she rapidly improved after biliary stent placement. She was discharged a few days later. The drain was removed, her surgical drain was removed in the outpatient setting, and this is a repeat cholangiogram on the right. You can see again with balloon occlusion. Now we see the cystic duct here out to the surgical clips, and we see those ducts previously with no, that we saw previously with no extravasation. So we're going to talk briefly about bile leaks. We'll talk about the location of this leak, which is a little more unusual than a classic bile leak, and treatment of bile leaks. So they can happen, it's variable in the literature, the incidence after cholecystectomy, up to 2% I saw in some studies. Clinically, if they have a surgical drain placed at the time, often a drain is placed if the surgery is a little more complicated. They can have bilious output from the surgical drain. If they do not have a drain, they can develop abdominal pain, distension, fever, jaundice from peritoneal absorption of the bile. They develop jaundice, or frank peritonitis, and that's how this patient presented. On imaging, they may have new ascites, as our patient did, or a biloma, which is a collection of bile. A HIDA scan can, in some cases, be useful if it's more subtle. You can see extravasation of the radiotracer. And ERCP, we don't use diagnostically. Generally, we have a diagnosis before we proceed to ERCP, or at least a very high suspicion, but theoretically, ERCP is also diagnostic and therapeutic. Now, as you can imagine, the most common place that a bile leak occurs is at the site where the surgeons transect the cystic duct, and there's just a leak from that transection site. But less commonly, they can come from these other abnormal ducts called the ducts of Luschka, which I will show in the next slide. This is Hubert von Luschka, and these are his ducts. So they're these slender ducts that come off usually the right hepatic duct, and they go directly into the gallbladder fossa to the gallbladder rather than going through the cystic duct. So when the surgery is performed and the cystic duct is transected, these are not really involved or formally clipped or anything. The gallbladder is just taken out after the cystic duct is resected. And in our case, again, this is the sort of exact image of the schematic, but I think they wrap around here off the right hepatic and come down. And treatment of bile leaks, which is the reason that we did the ERCP, is to reduce the pressure gradient out the leak. And so the reason that the bile is leaking out rather than going out the papilla is because there's something creating a higher pressure out of the papilla and diverting flow out the leak. And so our goal is to reduce that pressure in the main duct and let the bile flow the normal way, and then the leak heals, the body heals the leak on its own. So one of the things that can create that pressure is a retained stone. So sometimes you need to remove a stone from the duct. Another thing is the sphincter. And so sphincterotomy, you could logically assume, would reduce that gradient and allow bile to flow. And then the third thing you can do is you can place a stent, which opens up the papilla and allows bile to flow out that way. And there's some debate, I would say, different endoscopists have a different approach to this, whether they prefer to do a sphincterotomy alone to reduce the gradient, sometimes place a stent alone and spare the patient from a sphincterotomy, especially if they're younger, or perform both a sphincterotomy and stenting. And so I looked at this study, which was a large study that attempted to answer the question of which one of these therapies is better. And it was a retrospective study, but involved many centers with 1,000 patients who had bile leaks. And their main outcome was looking at adverse events after ERCP. And their actual stated initial goal was to look at how timing of ERCP affected adverse events, comparing emergent within 1 day, urgent within 2 to 3 days, or expectant management of bile leaks. And they actually showed a highest mortality in the emergent cases. You could say in a retrospective study that's sort of biased because you can imagine the emergent cases are probably sicker. So I don't make much of that outcome. But the other outcome that they looked at is that there was a higher failure rate in patients who were treated with sphincterotomy alone as compared to patients who were treated with stenting, either stent alone or combination therapy. So anytime they placed a stent, they had a lower failure rate. And so I think it is suggestive that the stent is very useful intervention in this case. And that is that.
So Nick has been somewhat of a magnet for these cases. He sort of jinxed our program. I would say that on average, post-surgical anatomy ERCP, we were doing a handful of these a year. They're not something that comes up much. But early on in Nick's fellowship, he innocently posed the question of, how come we don't see it? How come we don't do or see a lot of these cases? And then everything just exploded, and we probably do one a week now, and it's all Nick's fault. These are not fun cases. They're very frustrating. They're very difficult. But if I'm not mistaken, I think this was a case from August, and I don't think you knew what you were getting yourself into.
I had no idea.
You did a phenomenal job, and it was a fantastic case. So kudos to you.
Chris, it's Randy Steinhagen. Remember, we had that case of the duodenal stump leak?
Yes.
Similar idea.
Similar idea. I mean, it's you just have, it's all plumbing. And as Nick pointed out, you just have to divert the flow of in this case, bile to the point of least resistance, which is where the stent or sphincterotomy comes in. So Nick, one question that comes up, and I think you mentioned it in the slide, I don't know if you talked about it. I think in our own team, we debate whether or not we need to do a sphincterotomy or not. And my personal preference is, if they don't have a reason to have a sphincterotomy, if there's no stone, why put the patient through the risk of the sphincterotomy? You can simply put a stent in without a sphincterotomy. My thinking being, there's a risk of post-sphincterotomy bleeding. Why subject the patient to that? Did this study determine whether or not there were higher adverse events with sphincterotomy versus combo therapy versus stent alone?
Yes. So in this diagram, in this chart, on the left is sphincterotomy. On the right, that combination therapy is sphincterotomy plus the biliary stent. And so you could look at, well, this is failure rates for the intervention. They also looked at adverse events. There were no differences in adverse events in any three of the treatments. But essentially, it does make the argument that you could place a biliary stent alone with a very low failure rate without performing sphincterotomy, and then, as you said, spare them potentially the risk of bleeding or even later post-sphincterotomy complications like stenosis. For our surgical colleagues in the audience, can you comment on the duct of Luschka? Is this something you routinely look for during cholecystectomy? Is it sort of one of these rare things that we don't really think about much?
Yeah, why don't they bleed all? Why don't they leak all the time? That's what I've always wondered.
Okay, we try and put clips on anything that looks more than a millimeter or 2 millimeters, just for this reason. Also, you can reduce the chance of this happening by doing an intraoperative cholangiogram, because you may see it in the operative cholangiogram, and then you know to look for it. Basically, the principle is to do the cholangiogram before you take out the gallbladder, to give you a better idea of what the ductal anatomy looks like.
I've heard them be described from other surgeons as being like small cobwebs near the gallbladder, near the fundibulum of the gallbladder, that can be very hard to see. And if you're not looking for it, you won't find it.
Basically, you have to look for them. And if there's any question, just use another clip. There are plenty of clips available.
Excellent.
But Chris, my understanding is that they're pretty common. And so it's surprising, I guess, to me, that these little ducts don't leak more. Maybe they do and they're subclinical, but so that was my question for the surgeons.
It's just to clip them, or if there's any question, to leave a drain afterwards. If this patient had a drain left after surgery, this would never become a clinical issue.
Right. And then I have a question for Nick and then the whole group. So there's a patient on the service this week that has an enormous bile leak.
Yes.
And so the question that came up there, but more in general, was, whether if you choose to put a stent in, do you put the stent just across the papilla, or do you actually try to close the leak with the stent?
So this is another larger question. The success rate of just crossing the papilla is so high that in most cases, you do not need to cross or cover the leak. And so traditionally, we just place a stent through the papilla and a plastic stent is sufficient. In that case, the patient presented with a cystic duct leak and the patient had already had a sphincterotomy, which implies to me that the leak was so big that it was bigger than the biliary orifice with the sphincterotomy, which portended a high rate of failure with even a traditional therapy. And so we elected to actually cover the leak with a fully covered metal stent, which is what you would do in a refractory case. So you could almost sort of do it stepwise and generally just place a plastic stent. And then in the very rare case that the plastic stent alone fails, you could step up to a fully covered metal stent to cover the leak.
Thanks.
All right. Excellent. Thank you so much, Nick, for that case and for demonstrating your skill early on in your Jedi training here.
Oh, let me just add, that was actually unbelievably well explained. Like the diagrams and the arrows and the pictures make it really, really easy to understand. So
I thought it would be pretty confusing, so I tried to illustrate as much as possible.
It's pretty confusing in real time because you're looking at a papilla upside down, and we tend to look at the oriented on a clock face. So normally we do a sphincterotomy at the 11 o'clock position. Now, when we do this in a Billroth 2 anatomy, we're doing the sphincterotomy towards 5 o'clock. So your whole viewpoint just gets so altered, and you really have to stop and think about what you're doing because you can run into trouble pretty quickly. But as Nick pointed out, once you get access to the pancreas duct, you take it and you let that's your safety net to be a little bit more aggressive. All right, so in the last few minutes, I have a case that I would like to present. Everyone's seeing my screen?
yes.
Okay. So this, interestingly, isn't a case that involves endoscopy, but it is a fascinating case that I think is a relatively under-recognized cause of pancreatitis. So this is actually a pediatric patient that I follow. I met her in 2019. She was 13 years old then. She's 14 now. And she has a history of idiopathic recurrent acute pancreatitis. First episode was in 2017, and then she had 2 other episodes in 2019. All of these were uncomplicated, but they did require hospitalization. They were true pancreatitis attacks, elevated lipase, imaging findings consistent with inflammation. So, everyone sort of asked the question that she didn't have gallstones and she didn't endorse any drinking. So, I think in the local hospitals, they just sort of shrugged their shoulders and weren't really sure what to do. So I saw her after her 3rd attack, and we did an extensive history. So she had no evidence of gallstones. She had normal triglyceride levels, as hypertriglyceridemia over 1,000 can easily cause pancreatitis. Similarly with hypercalcemia, she had normal calcium levels. Things like celiac disease and IBD had been ruled out, as these can be associated in the younger population with pancreatitis. For whatever it's worth, a serum IgG4 was checked, which was normal. And then she had no suspect prescription medications, no over-the-counters. She denied any tobacco, alcohol, or illicit drug use, and there was no family history of pancreatitis or pancreatic disease. So in a young person, there are only a couple other things left to really rule out when you're looking for cause of idiopathic pancreatitis. So we certainly looked at an MRCP and thinking, could she have pancreas divisum, which is a congenital anomaly of the pancreatic ductal system, and her pancreatic ductal system was normal. And then we looked back at an old CAT scan, and what we saw, very subtle finding, was she had a calcification in her pancreas. So, the presence of a calcification in the pancreas is abnormal. It's not a routine thing. And it basically is consistent with chronic pancreatitis. So at this point, we now have a young teenager with recurrent pancreatitis, possibly early chronic pancreatitis, and with no explanation. So really the major category that was left to investigate was whether or not she had any genetic mutations that can be associated with pancreatitis. So we sent her to our genetic counseling team, and they performed something called the Invitae Pancreatitis Panel, which looks at a whole host of known gene mutations that are associated or implicated in causing recurrent acute pancreatitis and or early chronic pancreatitis. And sure enough, she tested positive for a PRSS1 mutation. So there are, as I mentioned, there are a number of gene mutations that are implicated in recurrent acute pancreatitis and chronic pancreatitis. And we typically think about these in the younger cohort. So not your 50, 60-year-old patient with unexplained pancreatitis, but more your kids, teenagers, and young adults. And to sort of summarize what these gene mutations do, they either work at the level of the acinar cell or at the level of the pancreatic duct cell. And the dysregulation either results in overactivation of trypsin or inappropriate inactivation of trypsin, or affects the secretion of pancreatic enzymes, sort of, the classic one being cystic fibrosis. If you have sort of thickened, inspissated pancreatic secretions, you're not flushing your enzymes out of your ductal system, and then you can have intrapancreatic activation of these of the pancreatic enzymes, leading to pancreatitis. So in PRSS1, the mutation results in inappropriate activation of trypsin. So you have inappropriate overactivation of trypsin, trypsin being the main enzyme that sort of sets the cascade of activating all the other pancreatic enzymes. And if you look at some data out there, this was a study from Hopkins. They looked back at the results of genetic testing in their patient population, and they found that for patients who had true idiopathic recurrent acute pancreatitis, when they did genetic testing, a gene mutation was found 58% of the time, PRSS1 being the most common. They also looked at a cohort of patients who had an unexplained first episode of pancreatitis that were below 35 years of age. And again, 63% had a gene mutation, with cystic fibrosis being the most common. So these are very difficult cases because there's not much we can do to alter the natural history. So her course, she had her initial episodes in 2017 and 2019. She did okay, and then she got admitted here in 2020, the end of 2020. It was a short hospital stay. I saw her back in the office in early January, and then a few weeks later, she had another attack, and she's been hospitalized here since. So, we've repeated imaging, and again, there's no complications of her disease. She doesn't have any pseudocysts. She doesn't have any necrosis. That calcification appears to have gotten bigger, but it's not causing any pancreatic duct obstruction. So there's not really a targetable lesion for us endoscopically. Her father is a physician and has been in touch with David Whitcomb, who's at the University of Pittsburgh. And David Whitcomb actually discovered the PRSS1 mutation. So he's a lovely guy, and he's been having a very nice email exchange with the patient's father. And he's pointed him towards some clinical trials that look at the use of antioxidants, which is something that we typically use in chronic pancreatitis patients who have chronic pain. It's a free oxygen radical scavenger that is supposed to sort of quiet the inflammatory milieu of chronic pancreatitis, but they're using it in these kids with genetic etiologies. And then the other thing they're looking at in a clinical trial setting is the use of amlodipine, because so much of these gene mutations, one of the critical steps in pancreatitis propagation is elevated intracellular or intracellular cell concentrations of calcium. So if it's been shown in rat models that if you can lower the intracellular concentration of calcium, it may, with calcium channel blockers, it may reduce the activation of trypsin. So that may be the next step for her from a clinical trial. Big picture standpoint, however, is really one thing, and that is potential total pancreatectomy with islet cell autotransplant. So this is an emerging treatment where patients with either chronic pain due to debilitating chronic pancreatitis or recurrent pancreatitis that's really impacting their quality of life, you remove the pancreas, you harvest the islet cells, and then they're injected back into the portal vein where they get taken up into the liver and allow the patient to maintain glucose metabolism, ward off the development of brittle diabetes or insulin requiring diabetes. So we've already broached that potential subject with her parents. We're hoping she's not at that point yet, but there is a sweet spot with these patients, because if they get more attacks and burn out their pancreas, you may lose the opportunity to harvest viable islet cells. And then if they get their total pancreatectomy, they have a higher risk of becoming a brittle diabetic. So,
Chris, I just sent you a paper. There are a number of surgical studies where even in patients who have not had imaging showing gallstones, you have about a 70% chance of stopping the pancreatitis with cholecystectomy. I think before she goes under that kind of a procedure, she should just have a lap chole first, and she may well get cured just by that.
I mean, her pattern is not typical for biliary pancreatitis. I think in an adult population, I would agree with you. Her patterns of pancreatitis are not associated with LFT abnormalities. She doesn't really have stones or sludge in her gallbladder. I don't disagree. I think it's a much less morbid procedure than a total pancreatectomy, but clinically, she's not behaving that way. And I think with the PRSS1 mutation, which is a known, it's an autosomal dominant mutation. It's one of the most common ones we find. I think that still remains high on the possibility. But your point is definitely well taken, for sure.
How many people have that mutation and don't get pancreatitis?
I don't think that's known. It has variable penetrance. That is for sure. But it's not something that's routinely checked for any other conditions. And, in our practice, that's sort of the last line of defense. I know a lot of other places check these genetic mutations early on in patients with, I don't really do this in patients who are in their 50s, 60s, and 70s who've had 2 unexplained attacks of pancreatitis. In a case like that, I would agree that a cholecystectomy is probably a more logical intervention than doing genetic testing. But in a kid like this, she's pretty classic for it. Any other thoughts or comments? I think we've run over our